I have a great pleasure in welcoming delegates and faculty from all over the world for this wonderful webinar. And this is our fifth series of webinar on gastroenterology, hepatology, and endoscopy. I am Dr. T.S. Chandrasekhar, your ACG Governor for India region. And I bring warm greetings as a member of webinar subcommittee of American College of Gastroenterology. And I also bring warm greetings from World Gastroenterology Organization as the member scientific committee and as the member of the Tamil Nadu Dr. MGR Medical University and our institute, Med India Hospital and Academy. The first four series of webinar witnessed the participation of over 24,000 delegates from all over the world. That really inspired and encouraged and motivated. Why not we have the fifth series of international webinar? And it became possible because all these webinars were endorsed by American College of Gastroenterology and some of the webinars by American Society of GI Endoscopy. Now, the fifth series of webinar, we started from April 26th. Now it's going to be there for 3 more years. I'm glad that I've been re-elected as the ACG governor. So I'll be continuing these monthly webinars. We gave a nice title, Name the Topic, the World Experts Are Here. And very catchy to say that the great news here, the new Endo-GE webinar series and the first of its kind where the webinars were 24 was inaugurated by none other than Professor Dr. Jonathan Lighton, President, American College of Gastroenterology, and Amy Accentank also was the participant in that meeting. And one of the webinars saw the witnessed the participation of the Nobel Prize winner, Professor Dr. Barry Marshall, the discoverer of Helicobacter pylori. He gave an excellent talk on the journey of discovery of Helicobacter pylori and further. It witnessed the participation of over 10,000 delegates from all over the world. That again inspired us. This is a fantastic platform to have delegates from all over the world. These webinars would not have been possible without the coordination from my colleague, Dr. Gokul, Satya, Yogesh, Prasad, Trinyana Sambandam, and our international medical director, Dr. T.C. Vivek Sandeep from USA. And this webinar is now going to be, it's become very prominent and it has become almost very important, their teaching tool among the gastroenterologists because of the participation of who is who in gastroenterology from Indian scenario and international scenario. And they have been the advisors for me, Dr. Nageshwar Reddy, Sareen, Ranjir Sood, Dr. V. Mohan, diabetologist, and Dr. Narasingan. And the middle level gastroenterologists were senior also, apart from the senior gastroenterologists, they have consented to be the moderators like Dr. Pravir Rao, Nalini Guda, Tushar Datta, and we have international and national panelists to contribute more for our webinar. What this webinar we have decided, we started from April 2026. We started with neuroendocrine tumor, gastrointestinal stromal tumor, then selection and optimization before liver transplant, post-liver transplant care, diarrhea in immunocompromised and irritable bowel syndrome, and see the kind of speakers we had were excellent. And now today we are going to have clinics in alcohol-associated hepatitis and the discoverer of MELD himself, the developer of MELD score himself, Dr. Patrick Comer, who is very familiar to Indian audience, is going to talk on both the topics, and I will introduce the moderators all soon. In August, we are going to have ulcerative colitis management 2026, Crohn's disease management in 2026 from PGI and AIMS faculty. And we are going to have dysbiosis and GI diseases, antibiotic right choice and rationale in GI infection, pancreatitis, and liver diseases. In October, we are going to have acute and chronic pancreatitis, natural history, complications, and management going to be there. So with this introduction, and Tamil Nadu Medical Council has recognized our webinars and has credited with the 1 credit hour. These webinars we are going to have today is alcohol related. It's a very, very important topic. There are a lot of recent advances happened. And everywhere, anything to do with the liver transplant and assessment of prognosis, a MELD score. Without MELD score, you cannot proceed further. And today's topic is going to be both related to liver, and both the talk will be by our the speaker and the Dr. Patrick Kamath, and moderated by Yogesh Chawla and Sanjeev Sehgal. Now it's my pleasure and a privilege to introduce the speaker. Patrick is almost a household name in hepatology in USA and India. So it summarizes his contribution, his dedication, and his determination to how he has evolved hepatology, how he evolved himself. And I can talk much more than anybody because I've been associated with Dr. Patrick Kamath from 1981 onwards. He's a professor of gastroenterology and hepatology, Mayo Clinic, Rochester, USA. One of the best hospitals everyone will dream of. He's a transplant hepatologist, Mayo Clinic, USA, focused on acute and chronic liver disease, non-alcoholic fatty liver disease, and polycystic liver disease, Buchiari syndrome, and various other liver issues. He's a special section editor, Journal of Hepatology since 2014. And I happened to visit his home. He had consecutively received almost more than 7 years Best Teacher Award. After that, he himself declined not to be received this award to give way to other people. And he's an associated editor, Hepatology Journal, 2007 to 2011, Clinical Gastroenterology and Hepatology Journal. He's a distinguished educator, Mayo Clinic, 2005. And you see the kind of publications you have an H index. And more than anything else, I can tell you that he is one of the finest human beings I ever met. He is always the best mentor I ever seen. I will not hesitate to say that part of my success is because of Patrick Kamath. And next, another equally a great human being is Yogesh Chawla. He is the chairman of Academies Kalinga Institute of Medical Sciences and Bhubaneswar. He has been the former director of PG, one of the most prestigious posts he was holding it. Former director of PGI Chandigarh. I happened to see him as the assistant professor of hepatology in Chandigarh when I was doing DM and MD post-graduation at PGI, and followed by, I've been closely associated with him. And clinical focus on liver transplant, management of cirrhosis and viral hepatitis. And he has been awarded several national and international awards. He has got a very significant publication. And it is, I'm delighted to say that if you want to have a friend like him, and you will be really gifted to have a friend. And another very enterprising and equally academic is Dr. Sanjeev Sehgal. He is the vice chairman and head hepatology and liver transplant medicine, Max Healthcare. And he is also PGI alumni. He did his MD from PGI Chandigarh. He is the founder, member, and former vice president of Liver Transplant Society of India, education committee member, International Liver Transplant Society. Principal clinical interests include liver transplantation, acute and chronic liver failure, non-alcoholic fatty liver disease, and alcohol-related liver diseases. So it is fitting to have both the Dr. Chawla and Dr. Sanjeev to as the moderator. And again, he has got a significant publications there. We have 3 young panelists. We have Dr. Mitra Prasad, She's from Coimbatore VGM Hospital, consultant hepatologist. We recently introduced, maybe not recently, a decade before, I suppose, DM Hepatology in Madras Medical College and Chandigarh, and other institution also. She is a DM Hepatology from Madras Medical College, PL Alagamai, best outgoing student of Madurai Medical College, and she is a consultant medical gastroenterologist, Meenakshi Mission Hospital, Madurai. Another equally very young, at the same time very dynamic, Ashwin Krishna, consultant hepatologist from Apollo Hospital, Chennai. And these webinars have been very successful. Today, I want to tell you that over 1,200 delegates from all over the world, they have registered. This is possible because what I did is, we have every state represented by one gastroenterologist eminent. They will propagate the vision and mission of this international webinar, starting from Chauval, Praveen Roy, Girish Kumar Patel, and Aravind Kumar, and everybody, and international ambassadors also we have from various countries. They also take up these webinars forward, and they become very popular among the Asian countries too. And before I conclude, I just want to invite you for our live workshop, also part of our ACG endorsement due 2027 in February 26, 27, 28. Now it's my privilege to invite Professor Yogesh Chawla to introduce the topic and welcome the speaker to start the first lecture. So we'll have it like that. After the first lecture, as suggested by our eminent speaker, we'll have a question answer session for 15 minutes or so. Then we'll move on to the second topic. Then we can have question on a second topic and first topic also. And finally, we'll have 10 minutes of chit-chat session. Thank you very much.
Thank you, Dr. Chandrasekhar. It's always a pleasure joining your ACG courses. I remember the earlier one that you got me into was on dyslipidemias and cardiovascular risks, where fatty liver disease was involved. And it's equally a pleasure to have chair a session where my very dear friend Patrick Kamath, we are both contemporaries. I was from All India Institute, he from PGI. And before he starts his talk, I would only say that, Patrick, you would agree that in 1980s, when we used to take rounds in hepatology, we hardly saw any patient with alcoholic liver disease. This has completely changed over the years. Since the year 2000. You only see alcoholic liver disease patients in the wards admitted with different conditions of these patients. It's been always an enigma, but since you are one of the best clinicians and a great scientist in hepatology with extensive work in alcohol, it would always be a pleasure to listen to you again this time. And I'm sure the delegates who have joined would be equally get a lot of information from your talk. Over to you, Patrick.
Can you unmute yourself?
Thank you, Yogesh, for that kind introduction. You know, you and I have been friends for over 40 years, and I've really treasured that friendship and our collaboration that we've had. TSC, you've been like a Thambi to me for almost 45 years now, and it really makes me very proud to see how well you're doing. So keep up the good work. So in this talk, on alcohol-associated hepatitis, I'll just go over probably the most important for a practicing clinician, okay? So first and most important to know is there is no safe level of alcohol consumption. So the best is no alcohol consumption. How much should you drink to get alcohol-related disease? Now, there have been different studies that have been done. Generally, it is 3 drinks per day for women, which is about 40 grams of alcohol. Each drink is 12 to 14 grams, and 4 drinks per day in men. And there's a very strong correlation between severity and duration of alcohol use and presence of cirrhosis. So once you have alcohol-related liver disease, 3% will progress to cirrhosis every year. But it's also related to how much people drink. If they drink more than 30 grams per day, then 2.2% per year. Less than 30 grams, 0.08. But look at this. If the consumption is more than 120 grams per day, that is 13.5% risk of progression to cirrhosis every year. So clear association between amount of drinking and risk for cirrhosis. But I want to caution you about this. These studies are from the West, where the BMI is different, the muscle mass is different, and I think we really need very good data from India related to levels and types of alcohol and relationship to liver disease. Now, if you look worldwide, you can see this red line, that is 50%. So you can see there are many areas of the world where more than 50% of all cirrhosis are related to alcohol. So this I've taken from publication from India, 43%. But like I'm going to show you in the next slide, I think this is going to increase, and that's exactly what Yogesh was trying to say. This is because of the growth of alcohol use in India. So just think about this. How much do you think it's going to increase? 5 million to 11, 55 million to 110, 5 billion to 11 billion. So we're talking only about 10 years. Or is it 55 billion to 110 billion? And the answer is actually, look at the amount that is being spent on alcohol in the country right now. When I say spent on alcohol, this is amount that is produced, but it's going to double in the next 10 years. And $110 billion is 10.35 lakh crores. So that's how much alcohol is being produced in the country. So it's not surprising that alcohol-related liver disease is increasing. So with that as a background, let's take a case scenario. 38-year-old male, alcohol use disorder. Now you'll see younger and younger people with alcohol-related liver disease, high MELD, jaundiced, creatinine up, pulmonary infiltrates, hypoxemic, hypotension. You're likely to be seeing this patient almost every week. And when you see a patient like this, these are the questions that come up. Should we use steroids? Patient is infected, which antibiotic should we pick? There are some spots on the lung. Should we consider antifungal infection? Should we cover Candida and Aspergillus with anidalofungin? What about transplant in these patients? So these are the usual thoughts, and I'll discuss this today. So unfortunately, these patients, once they get very sick, they're likely to die. So this is a patient with Klebsiella pneumonia, more confusion, endotracheal intubation, more lung infiltrates, antifungal treatment started empirically, and ultimately, unfortunately, this patient dies. So the diagnosis here is alcohol-related hepatitis leading to multiple organ failure. Some of you might call it ACLF. That's okay. Remember this, most important of all, alcohol-associated hepatitis, the diagnosis is essentially bedside, and you make it very quick. You have a compatible history, you have a clinical picture, and you have some lab findings. And when you say alcohol, that's going to be based on your history. We don't have a blood test to say this is alcohol-related hepatitis. And the hepatitis, I told you about, there's a clinical picture and compatible laboratory test. So that's how you make your diagnosis of alcohol-related hepatitis. So to summarize this case, this patient had liver injury, developed a systemic inflammatory response, got infected, and then had multi-system organ failure. So let's go over what happens here. So the normal hepatocyte takes up ammonia and releases urea into the circulation. The normal hepatocyte also divides, through mitosis and produces daughter cells. So that's the regenerative capacity of the liver. Alcohol damages the liver, so the liver cell dies. So ammonia cannot be taken up, and ammonia and many other waste products then get into the circulation. Dead cells attract inflammatory cells from the extracellular matrix. These inflammatory cells will produce pro-inflammatory cytokines, which again get into the circulation. Pro-inflammatory cytokines, especially the histones, will inhibit mitosis. So the end result of alcohol injury to the liver is you see various consequences of liver failure, systemic inflammation, and impaired regeneration. So to put it another way, patient gets alcohol-related liver disease. They have a systemic inflammatory response. Then they get infected, which worsens the systemic inflammatory response. They get organ failure, and then they die. And so this is the typical course, the previous slide in another way. So they have underlying liver disease relatively compensated. There is harmful alcohol use. You get hepatic and extrahepatic organ failure resulting from inflammation. The inflammation may be sterile from liver injury or infection related. These people then get an infection with impaired regeneration, which worsens hepatic and extrahepatic organ failure. But if you treat the inflammation, if you treat infection, the alcohol use disorder, maybe some liver support, perhaps these patients return to compensated liver disease. So in this talk, I'll go over a few points. How do you diagnose alcohol-associated hepatitis? What is the current medical management? The role of liver transplantation? Other than steroids and transplant, what can you use? And then some take-home messages on alcohol-associated hepatitis. So diagnosis. Again, remember, so the diagnosis is simple. So the initial evaluation is, you have a patient with heavy alcohol use, recent onset of jaundice, your blood test, typically bilirubin greater than 3, AST greater than ALT, and greater than 2 times the upper limit of normal. You have a differential diagnosis. Don't straight away make a diagnosis of AAH. So biliary obstruction should be ruled out. Drug-induced liver injury, take a good history, viral serology, autoimmune markers, and ischemic hepatitis. Areas of when you have hypotension, you can have elevation in the liver test. Later on, they can get elevation in the bilirubin. Patients with alcohol tend to have falls, tend to get hematoma. So rule out all that. Once you have ruled out that, and you make a diagnosis of alcohol-associated hepatitis, consider treating the alcohol use disorder and liver-related complications besides the alcohol-associated hepatitis. So we'll talk about alcohol use disorder management later, hepatic encephalopathy and GI bleeding, infection, and acute kidney injury. So let's go to the management of the alcohol-associated hepatitis, and currently it is steroids. Only a small percentage of patients are candidates for steroid treatment, but it tends to be a useful drug. So typical presentation, history of alcohol use, lab test AST greater than ALT less than 400. That's typical of alcohol. Clear history of alcohol use, no potential hepatotoxic substance in the last 3 months, no hypotension, nothing else. All yes, you say this is probable alcohol-associated hepatitis, which is a clinical diagnosis. If you choose to do a liver biopsy and you confirm by histology, this is definite alcohol-associated hepatitis. So biopsy proof makes it definite alcohol-associated hepatitis. If there's a question about alcohol use, because patients and family might deny alcohol use, you're not sure whether they've taken a drug recently or not, the lab tests are not quite right, If any of these is no, you must do a liver biopsy before you can say alcohol-associated hepatitis. Without a liver biopsy, it's only possible alcohol-associated hepatitis, clinically suspected, but you cannot start treatment as AAH. But probable and definite alcohol-associated hepatitis, TF greater than 30 or MELD greater than 20, consider prednisolone 40 milligrams per day. MELD score at the end of a week, less than 0.45. Continue treatment for 4 weeks. And you might be aware there's a very interesting study by Anand Kulkarni from Hyderabad. So instead of using the same dose throughout, they tapered by 10 milligrams each week. At the end, there was no difference in mortality, but infection was much less when you had a tapered dose of prednisolone. So we need that study reproduced, but I think that's a thought about how we should go about treating some of these patients, and we'll discuss that later. But at the end of 7 days, if the MELD score is greater than 0.45, that means this is a non-responder. So you have to stop the steroids. Selected patients consider early liver transplant. Typically consider these patients for clinical trials. And if they have multiple organ failure, like our patient, you have to talk about palliative care and, about goals of care in these patients. So this is really an end-of-life discussion then, if they're not transplant candidates. So which patients benefit from steroids? And this is the work of J.P. Arab, one of our previous fellows. These circles tell you the mortality in patients at 30 days based on the MELD score. The squares tell you mortality in the control group. So this is from all the different studies. So highly efficacious is greater than 20% difference. So this blue, the darker blue, is the area where the greatest benefit is. So in general, MELD score over 20, there is a benefit with steroid treatment. Maximum benefit is between 25 and 39. Over 50, there is no benefit. So that is really futility. And again, survival benefit was at 30 days, but not 90 or 180 days. So that's steroid treatment, whom to treat and how to treat. What about liver transplantation? So in these patients, we consider the early liver transplant for severe AH algorithm. So severe alcohol-associated hepatitis, responded to medical treatment, continue medical treatment, not a candidate for liver transplant at this time, not for early liver transplant. If they have non-response to medical treatment, then you consider an expedited psychosocial evaluation, an expedited medical evaluation, and these are not easy decisions to make. If at the end of it, the consensus is not achieved, then the candidate is denied liver transplantation. But if you achieve consensus, then this candidate is accepted and listed for early liver transplant. Who's a candidate? Very carefully selected patients. So generally only about 10% of all patients will be candidates. They should have no ongoing extrahepatic infection. You have to look at the patient, look for frailty, look for sarcopenia. They should be not on vasopressors, or at least vasopressors should be decreasing. Experienced liver transplant centers, these patients are very sick, so you need a very good team to look after these patients. Limited social and medical risk, all of which decrease the complexity of the procedure. And then you also need a good donor liver. You need the liver to be working right away. For you, it's probably less of a problem because it's mainly living donor, but can I have a donor? I think you need to have a good donor for these patients. But remember, most parts of the world, they do not have access to liver transplant. So this is a good figure showing you access to liver transplant. So we're looking at centers and whether they could send for liver transplant. Doesn't mean all these patients are referred, but you're only looking at possibility. So USA, 97%, So Asia in general is about 18% of patients might actually be referred for liver transplant or can. We're only talking about possibility here. In Africa, it's down to 7%. So, liver transplant is possible, but only in a small percentage of patients worldwide. But what are the benefits of liver transplant? So, this is a good paper. This is from Ramon and then my colleagues JP and Vijay Shah. So the first block tells you the inclusion criteria, the endpoint, and the location of the study. You see the endpoints are a little different, sometimes 6 months, sometimes 1 year or 5 years. But I think this is important. This box here shows you early liver transplantation for severe AH as compared to liver transplant for alcohol-related cirrhosis. So you can see the results are actually quite good. On the other hand, severe AH who don't go to transplant, survival is poor. So yes, there is benefit of early liver transplant. The next question always is, do they go back to alcohol use? Remember, ALD cirrhosis without age, you still have a little while to get them rehabilitated. So the risk of going back to alcohol is lower than with severe AH. But generally, we say about 20% with ALD cirrhosis, about 30% with severe AH. So yes, liver transplant has a role again. What about other options? Remember, treatment of infection and nutrition, really important, GCSF and FMT, liver regenerative treatments, and maintaining abstinence. That's really important in patients. So infection and nutrition, we don't have time to go over everything, but in general, for instance, like in our patient, as soon as a patient is admitted, you'll do paracentesis, blood cultures, acidic cultures, urine, chest X-ray, lactate. And we would initially do chest X-ray. But Alex Louvet from Lille, he taught me one thing. He said, you do this chest X-ray, they are intubated. But if you do bronchoalveolar lavage, many of them have pneumocystis, they have fungal infection, and these are the ones who die post-transplant. So for the past 4 or 5 years, they've been routinely doing a chest CT in people going for liver transplant. I think that's a good idea. Once you've selected them, make very sure they don't have lung infection, because lung infection is what kills these patients. We treat the infection, which antibiotics, you can pick whichever. I don't know what is best in India. We typically use piperacillin and sulbactam, but if they're admitted to the intensive care, and especially if they're transplant candidates, we try and hit them very hard. Inadequate response to treatment, antifungal treatment. Fluid resuscitation, therapeutic paracentesis, make sure they don't aspirate. DVT prophylaxis, stress ulcer prophylaxis. Despite that, the mean arterial pressure is less than 60, norepinephrine. Still less than 60, persistent shock, hydrocortisone. The patients who are in septic shock and persistent shock are probably not good candidates for liver transplantation. What about prophylactic antibiotics? Once you start steroids, again, this is a study from Alex Lober in JAMA 2023. Amoxicillin and clavulanic acid did not help in these patients. Big concern, especially in India, is increasing risk of multi-drug resistant organisms. You have to be careful about prophylactic antibiotics too. And unfortunately, we have limited antibiotics in the pipeline. GCSF, FMT. GCSF has been promising in studies in India, but not outside of Asia. FMT benefit in severe AH in pilot studies. We are waiting the results of larger randomized trials. There's probably something there. In addition, FMT may reduce alcohol relapse. Liver regenerative treatment. I think this is new, and this is part of a study that we are currently doing. It's amazing. Lower vertebrates regenerate very quickly. They lose a limb, they can regenerate. Mammals, liver, cut off part of the liver that regenerates. That's the basis for living donor transplant. So healthy hepatocytes regenerate. But if you damage the liver, if it's acute injury, there is regeneration. But if there's chronic injury, there's extracellular matrix which accumulates, and this seems to impair further regeneration. So if you try and find a way to block ECM accumulation to allow regeneration. So basically regeneration is impaired with chronic liver disease. Do we have a drug which helps? Maybe. So IL-22, it's a fusion protein. So it decreases inflammation, which is very good for AH. It promotes regeneration. And most important of all, it doesn't impair immunity. So if the patient is infected, you can use it. Unfortunately, you cannot use steroids in these patients. In our pilot study, with MELD scores 11 to 28, we tried different doses. And you can see there was benefit here. But remember, there's no control group. So maybe it was just because it's not drinking, we don't know. And so IL-22 is now part of an NIH study which has just started. 9 centers in the US, but mainly 5 who are doing it. They're going to be given steroids or IL-22. So we want to see whether regenerative treatments help. And maintaining abstinence is really important. So if you look at alcohol-associated hepatitis prognostic factors, if you have severe age, the severity at baseline and response to treatment at day 7 will determine whether the patient is alive at 6 months. Now, if that patient does not drink and has responded to treatment, they have minimal risk of death. They don't require liver transplant. If there's no alcohol response, but they have not responded to treatment, they have a substantial risk of death. But because they've not had an alcohol response, relapse, they are candidates for liver transplantation. The biggest problem is patients who have not responded to treatment, alcohol relapse, they have a high risk of death. And these are not good candidates for liver transplant. And you have to consider palliative care. So in the short term, target liver injury. In the long term, target alcohol behavior. And unfortunately, all our studies have looked only at liver injury. So the new study that we've currently started is steroid in one arm and IL-22 in the other arm. IL-22 given at day 0 and day 7. At day 7, patients will be randomized to standard of care or a camprosate. So we are adding a drug in there and then looking at long-term relapse. Because 30-day mortality is not good enough for any study. We have to look at longer term. So we're looking at survival at 6 months and 1 year. Which drugs to be used? So this is a paper in Hepatology last year. This is for alcohol use disorder across. We're not talking specifically about liver disease. The most common drug used in the US is gabapentin, and it's not FDA approved. So gabapentin is safe in liver disease because it goes to the kidney, but we don't like to use it in patients with advanced liver disease because it makes them sleepy. And also there's a risk of dependence with gabapentin. The drugs which are FDA approved are naltrexone, acamprosate, and disulfiram. Naltrexone is a good drug. I actually like naltrexone. 50 milligrams a day, single dose, not complicated. If they cannot take early, they can get a shot every month. It's injectable. Unfortunately, there's a warning which says don't use it in severe liver disease. So we cannot use it in severe alcohol-associated hepatitis in there. Acamprosate is safe in liver disease, reducing craving, no hepatotoxicity concern. If the creatinine clearance is less than 30, then we cannot use the drug. So that is the reason acamprosate is being used in our study. And disulfiram or antabuse, because it's metabolized by the liver, in patients with liver disease, it's associated with higher mortality, so we don't use that. So we are really left with two drugs to use in alcohol-associated liver disease, naltrexone, which I think has many benefits except in very severe disease, or acamprosate, but we have to look at the results of these studies. Now, most patients with alcohol-related problems are going to find it difficult to come to work. They're not allowed to drive if they can drive. So can we monitor them digitally? And this is work done again by my colleagues, Dr. Simonet and Tiffany Wu. So we give the patient an app and they can download it and they can give us permission to track. Okay, so we cannot track unless they give us permission. So they have the track, so then we can know when they're going to bars, when they're going to get alcohol, and then an alert goes out, just warning them, say, be careful, you're too close to a bar, you're going to drink. Additionally, we can track mood, we can probably figure out whether they are withdrawing, whether they have craving because they have to speak. So I think this is going to be the future of monitoring in patients with alcohol use in general, but in alcohol-related liver disease. So finally, my take-home messages on alcohol-related hepatitis. The benefit of corticosteroid is limited to select group of patients, and with MELD score 25 to 35, and for a limited duration only. Liver transplantation, it has long-term benefits, but again, unfortunately, highly selected patients and much of the world does not have access to liver transplantation. Studies are ongoing to target inflammation. We need to integrate alcohol use disorder treatment for all age treatment because long-term survival is clearly related to continued alcohol use. And digital devices may be used in managing patients with AUD. Thank you, and I can take questions.
Thank you, Patrick, for taking us through alcohol-related liver disease. We could have questions from the audience. We could look at the chat box. But Patrick, just a point before the questions come up. In India, we have a lot of country liquor being taken. So the usual concept that after 10 years of alcohol intake, the patient develops cirrhosis. That may not be true in the Indian context, especially people who are drinking the country-made liquor, because it has a lot of impurities and the amount of alcohol also is different. Second point is whether continuous drinking is more harmful, or if you give breaks like binge drinking, would it produce less amount of alcoholic liver disease? Third is the role of PET in managing these patients during the alcohol use disorder, because these patients usually tend to go back to alcohol. So if you could have repeated PET estimations, which is not being routinely done in India, but I think it has a lot of potential to pick up cases. And since steroids and transplantation are not frequently tried in India because of different contraindications, my personal feeling is any patient with alcoholic liver disease, of course, not with a MELD of more than with 3-4 organ failures, but anyone with a preserved albumin, which I mean around 3.2, with low risk varices, I think should be given good nutritional support. And I've seen a lot of patients coming out of getting recompensated rather than subjecting them to liver transplant. So the balance between liver transplant and conservative therapy, if you're not able to give steroids, is very tricky. But some of my own personal is that anyone with a good albumin and with low-grade varices should be given a longer trial of nutrition before you subject them to surgery.
Patrick, you want to take up the questions first?
Yes, actually, Yogesh, also very important points. And I sort of did, I'll go over point one by one. That's why early in the talk, I said we actually need data in India on this.
Yes, yes.
So animal studies show that acetaldehyde damages the liver more than the actual alcohol. It's a breakdown product. And you know that country-made liquor has a lot of acetaldehyde in there. I think you can probably get bad liver disease much quicker with that. One of the difficulties in doing a study will be there is no standardization of that drink. Today it might have acetaldehyde, tomorrow it may not have. It's not a
Yeah.
really good process, but we definitely need studies on that. How to do it will be a little more challenging. So this binge versus continuous drinking, I always had the impression that the people who are drinking continuously and then have a binge will get more severe alcohol-related hepatitis. I still sort of feel that, but there is a study which came out of Denmark which looked at that, and they said it's more the amount of alcohol that you use continuously rather than that intermittent binge, which is associated. Because, in Denmark, they can track these populations. So that's what they said, even though I must say, I still need a little more conviction, but it looks like a large amount continuously will be more of a problem based on that study. PET is important. PET is important on multiple areas. So PET as a marker of drinking, selection of patients for transplant, while they're waiting to see if they're drinking, follow up for transplant. MELD, there is the study from PGI. MELD, you look at PET, lower PET, less decompensation. So PET is more recent. One issue, I think when I was talking, people in India, they were using ELISA for PET. Only very few centers were doing, and they were doing ELISA. So mass spectroscopy is much more accurate, and ELISA has problems. So it's also the method that you use to check PET. But eventually, that's going to be part of our study, but I hear it's quite expensive if you want to get it done outside of research studies in India. And then the nutrition, clearly, the initial studies in France showed they responded very well to steroids. The US studies, which were done in veterans, they didn't respond too well with steroids, and they said that was nutrition. Good nutrition has actually helped in these patients. So I think good nutrition has to be part of all treatments. Whatever treatment you use, nutrition has to be part of it. There's a group who can probably do well without steroids with nutrition alone, clearly. So I agree with that.
Okay.
Yeah, binge drinking is something more to do with the pancreatitis also. Those who had binge drinking, they develop more severe pancreatitis acute. The continuous drinking with the alcoholic. You are trying to relate like that, Dr. Chawla, where binge drinking is more harmful than
Yeah.
continuous drinking.
That's right. That's right.
Yes.
We'll move on to Dr. Sanjeev. You have a questions and comments, but
Thank you, sir. I've been absolutely delightful lecture, Professor Kamath. The problem which I face in our practice here, most patients are coming with very high, MELD score, and the DF is very high. Literally, they are coming with, DF more than 100, MELD, at the upper limit. So and there is a big risk of sepsis. So we are constrained in using steroids in these patients, most of the times. At the same time, the huge dilemmas of liver transplant because they're very sick patients. So, I just want to ask you, sir, when you use steroids, because that is what something has been shown as to be effective. What are the absolutely, absolute markers which you say that no, this must not be there. If it is there, I'll not use steroids. What are your absolute, pointers on this, sir?
Yeah. So Sanjeev, that's a good question. And if I go back a little, One of the main reasons why we push, IL-22, we did the studies here now, we pushed is because I keep thinking of India. You cannot use steroids there because A, they're so sick. We need some regenerative treatment, and you need to be able to give them a drug which is safe in the presence of infection. And IL-22 is safe in the presence of infection. It doesn't interfere with the immunity at all. So that's why it's a good drug. So steroids, there are many reasons why we may not use. So if you look at all patients with steroids, with severe AH who have a DF over 32 or MELD greater than 20, only about 10% can actually get steroids. The number one contraindication in these patients is infection. You have to look extremely carefully. So if you remember the New England Journal study of 2011 from Lille on early liver transplantation, their survival at 5 years was only 73%, the first paper. And they had patients who died, who were transplanted and died because of lung and fungal infection. So they realized they were missing infection. And then when you treat with steroids and transplanted, these patients had severe infection. That's the reason they also moved to a chest CT scan to look for lung infection. They do bronchoalveolar lavage in these patients if they are intubated. So they look very carefully for infection in these patients, and their survival has now gone up to 85%, just like everything. So it's infection which really kills these patients. So we typically do urine culture, blood culture. We used to do chest X-ray, but now I'm going the extra distance to use a chest CT. If they're infected, they're not a candidate for steroids. We're also worried about C. difficile in these patients. Mortality is high in C. difficile if you give them steroid. So that is number one. Second is creatinine. So creatinine is greater than 3. They are non-responders and they get a high risk of infection. So creatinine greater than 3, we will not use steroids in these patients. 3, GI bleed. Recent GI bleed, again, is a contraindication for steroids in these patients. So you can see there are many reasons. Patients come with a hemoglobin of 9, stool may be a little red, black colored stool. So it's safer not to give them because anyway, the benefit is only 30 to 40%. Even people who are candidates, not everyone will benefit.
Right.
So you have to be very careful.
Right. Thank you, sir. I think that's a very useful
Thank
message for all of us, sir.
We have some comments from panelists, Dr. Mitra Prasad, followed by Dr. Ashwin.
Sir, hello. Thank you. That was an amazing lecture as usual from Patrick Kamath sir, and thanks sir for getting this whole thing here. So what we find in the south of India is one, the pattern of drinking, as sir clearly specified, the muscle mass of the people. A lot of vegetarian population, so they do not tolerate the entire course of alcoholic hepatitis quite well. My specific questions to sir would be, sir, you spoke about cysts and an infection worsening things. What we find is in these patients, when we use steroids and bring down significantly the liver injury, on a long term they go into cars. So once the compensatory anti-inflammatory response syndrome comes in, that's when they crash with the worst of the fungal infections. So they do crash after a span of 6 months, 5 months. So this subacute failure, if you may term it, what do we do with it? Are the liver regenerative therapies going to help in that count? That's my first question to sir. Second one is, we find pancreatitis as one very silent thing in all these patients. Even though there is no structural damage evident on a CAT scan, these patients do have enzyme elevations, and once treated, the bilirubin tends to come down, and some process on to a prolonged cholestasis as well. So there are three different subsets that we keep seeing, and how to target these patients on a long term when they don't have transplant options is my question to sir. So,
Yeah, no, Mitra, I think those are very good points. So nutrition is really important. And how do we get nutrition better? I'm largely vegetarian now, but I think my nutrition is good. You can get enough protein if you want in a vegetarian diet. Generally in a South Indian diet, the biggest source of protein is rice. So that it's just because we eat a lot of rice as South Indians. That is the major source of protein.
Which one you
Unfortunately,
said, Patrick? Rice? Which one you protein?
rice is a big source of protein, even though the protein is only 3 to 4 grams. It's the
Okay.
amount of rice that we give, which gives us about 20 to 25 grams per day. And in some, that is the only source of protein that we have in a South Indian diet. It is when you add on the lentils, when you add on the dal, if you have enough sambar, that adds on. But remember, the poorer population do not have other things in there, so it's largely rice. So that is the reason for protein deficiency in South India. It's predominantly rice-based diet. So this is the work done by Prakash Shetty. That was his great paper in maybe the 70s about South Indian diets. So nutrition is a national problem. How do we get it better? I don't know. We have to do that. The cause and SARS is so that is the biggest problem here because they get the advantage first. So inflammation is actually good. And that's the paradox. You're getting so much in terms of neutrophil production, and yet they're getting so infected. And this is what we know. Neutrophils release what are called extracellular traps. Neutrophil-related extracellular traps trap platelets. And platelets set off a clotting cascade. And for various reasons, they decrease permeability of cells and you get cellular edema. So that actually is the cause leading on to organ failure. But this delayed thing, Mitra, I don't think is related to the initial event. I think most of these people are probably drinking again. Or they're getting it because when they came in, they already had cirrhotic stage liver disease, which is just progressing. I cannot relate 6 months later fungal infection to the initial infection. And yes, the pancreatitis and liver disease, every time I come to India and I go on rounds, I see this combination. And I think we have acute pancreatitis with cirrhosis, without cirrhosis, alcohol related. I think the outcomes are going to be different. We also get thrombosis in these patients with portal vein thrombosis. But I think the acute pancreatitis, especially in the head, increases liver tests. And when that subsides, the liver tests get better. So not all bilirubin elevation is related to liver disease, not AST in these patients. Yes, there is a combination of that.
How reliable the history given by the alcoholic patients or relatives? Sometimes, as you said very clearly, the alcohol history may deny also, but some worsening if you really go into the detail. The history is so unreliable. And it is there in Western population also, or we are only getting that kind of, what is any data available or study available, reliability of alcohol intake among.
So getting a history of alcohol use is an art. It's very difficult. So we know clearly there are studies done in the West where the amount of people say they drink, when families have recorded, is half of what they actually drink. So the general rule is double the amount of alcohol use. There's a paper in Lancet Gastroenterology. Israelson is the first author. When they looked at MELD, MET-ALD, and ALD, because you're looking at the history and they're looking at death. So in patients with MELD, who say they don't drink, they are not actually drinking. So PEth is low. In MELD, when people say they don't drink, you can get PEth positive. Because those with ALD, the levels are much higher than they actually say they are drinking. So it is unreliable. Takes a lot of time. I spend a lot of time with these patients. The first thing is the moment you say how much you drink, they get very defensive, because no one wants to admit the drinking. So the general way you're supposed to ask, I'm looking at different risk factors. Can we discuss alcohol use? Ask them and their family how much alcohol they buy, not they drink. If you buy a bottle a week, but you say I'm only drinking 20 milliliters per day, that doesn't make sense. So the amount that they buy is a useful way of finding out. And unfortunately, we have only one time that we ask them. It's the first time you meet them. But you see, after 2 or 3 days, when they trust you a little more and when you talk to them, they'll give you much more alcohol use. So in France, and Sanjeev, you know this, in the liver transplant protocol set out in Lille, they have
Right,
an
sir.
inner circle. Inner circle is the resident, the nurse, and the fellow. Those three have veto power over transplant because they get the best history. Consultant sees the patient for 15 minutes a day and is gone. The resident, the nurse, and the fellow will say, I don't think the history is good. They are meeting people. Someone has told them what the problem is. I think that's what you have to rely on a lot. In general, I rely more on younger people than people my age. Younger people are much better at many of these things.
The French model has said there's multiple layers, and the outer layer was the doctor, innermost was the nurses and the residents. You're so right, sir. So one problem which we face in our practice, I'll tell you the practical point. Honestly, because of the huge insurance issue in India, especially North, I don't. That's why it is. Patients are so scared in coming up with a true history, which is a practical point. They're very scared, because the moment sometimes what happens that somebody may be having hepatitis B, and by mistake he says alcohol, yes, and the insurance get cancelled. So there is a bit of dilemma. And although this is not a like I wouldn't say it's a very difficult thing, but fact is that merely mentioning alcohol and getting a label may not be the best idea. There has to be more quantification, and we should be having something which we can do with PET and all something so that we get a very strong labeling reason for alcohol liver disease, sir.
Sanjay,
Yeah,
you are right.
so-
Actually, they're always ready to object and reject in insurance. So occasional alcohol need not be recorded. Sometimes that they'll take it a point, they'll reject entire claim also. So if you are really, you have assessed him very well, and he occasionally takes alcohol, better not. But it's a full-blown alcohol liver disease, you can't deny that.
Absolutely.
Patrick, you wanted to say something? Patrick?
No, it's the world over. Human beings are the same. No one wants to admit faults. Insurance companies are waiting to deny for different reasons. If you just say cirrhosis, everyone thinks you're drinking even if you've never had anything. That was a problem with the original NASH, why the term was used. In another talk, I'll go over it, because NASH was described by Jürgen Ludwig, and this is at Mayo, and so there's the story of why it was called NASH, because we'll talk about that some other time. No, there is a stigma, but only I think government policies can make a change. The excise, governments run on excise duty. They get a lot of money from alcohol. So it is not to government benefit to decrease alcohol. They want the money, and that comes from alcohol use. But unless government makes strong thing of decreasing alcohol, it won't change. Alcohol-related liver disease, as Yogesh said, will increase and will continue to increase as long as we increase production and sales of alcohol.
Patrick, you hit a nail rightly there. The government earns in the excise duty, and that is the main source of income for the government comes. And I see in India there is a sea change that happened in the last 2 decades. What I've seen as a resident now, the alcoholic intake has gone and the number of people drinking also. In fact, the other way, in 1980 when I used to take history, the number of alcoholics used to be very less. Now in 2026, the number of non-alcoholics are very less. So yeah, that is a sea change happened. In fact, I used to tell my fellows, we lost one generation of people because of the alcohol. When it is freely available and government itself promoting for the excise duty, they should find another way of income rather than alcohol. There are 2-3 states in India, they're dry state. One is Gujarat and other one is recently I visited Bihar for Patna for the APA conference. That's a dry state. So they make up with some other revenue also there. So this is the most important point I think you nicely highlighted there. Government should the machinery where you can make a sea change among the common man. Otherwise, they're easily vulnerable for alcohol. Before Ashwin asks some question, Vivek, you have a question?
Yes, yes. Thank you for a great talk, Dr. Kamath, as always. I have a quick question. How does a 4-day LIL score compare to a 7-day LIL score? I see a lot of people making treatment decisions, calculating LIL score on day 4 and deciding whether to give steroids or not.
Yeah, so the question here is day 7 versus day 4 for LIL score. The most widely validated is 7 days. Perhaps 4 days is also good enough. Remember, the LIL score, once it's developed at 7 days, is going to be the standard for all studies. So we have not reached a stage where we can switch to 4. But we use 4, say, outside of studies. Generally you look at the patient and you're not getting a response, you're getting worse. And then if this is going up, all the LIL score tells you is the difference in, it's got many factors, but it's dependent on only one thing, the bilirubin. If your bilirubin is going up, the LIL score will go up in older people. Younger people, it still may not go up. So if your bilirubin keeps going up despite treatment, whether it's at day 4 or 5 or 6, I think it's time to consider stopping.
Okay, thank you. Dr. Ashwin, you have a point.
Yes, sir.
Yeah.
Sir, I have one doubt whether a liver volume, CT liver volume can be used as a prognostic factor, number one, or can we use it for giving steroids? That is the question. Second question is, can we taper the dose according to the severity? Severity in the sense when the patient is having mild infection, can we give a lower dose, or can such even the CMC has published a paper that low dose steroids with the plasma exchange can help in the alcoholic hepatitis related ACLF?
Okay.
So 2 questions. One is volume. I am not aware of any studies which have used that. To me, we're just adding complexity and expense. CT scan, taking it one and then getting the volume and really not knowing what to do with it. You'll have to have a huge number of patients before you say you can use that. So I'm not aware of any studies and we don't use that. The second question on steroids is probably important. So I was talking about Anand Kulkarni's study with the lower dose was not inferior to the standard 40 dose. You have to go back to find out why 40 milligrams was picked, why for 28 days, and why no taper. So when Willis Madrid did a study at Johns Hopkins, these patients were allowed to be admitted to what's called the clinical research center. At that time, the NIH allowed you to admit patients for research studies, and the NIH would pay for the bed. So the patient didn't have to pay for it, insurance didn't have to pay. So they had to pick a dose of steroids. They picked 40. They said if we use more than that, maybe they'll get infected. If we use less than that, they may not. And they were picking about 0.5 milligrams per kilogram for the dose of steroids. They could admit the patient according to the clinical research center rules for 1 day, 3 days, 5 days, 7, 14, or 28. You could admit. Willis said, I don't know, let's take them for 28 days. So he could book the bed for 28 days, new drug. But once the study was over, they left. So there was no steroid treatment. So it was not based on a study that 28 days is better than 14. They just, which was most convenient. In the JHEP study from the US, which was published on when anakinra versus steroids, in those who stopped steroid at 7 days, remember previous studies, control group continued steroids for 28 days. There was no allele stopping rule for the studies. When we use the allele stopping rule, those people actually did it quite well. To me, more important than a lower dose is the same dose for a much shorter period of time. And that's a study that needs to be done.
Dr. Raja Pandey, then you have a question. We have two PG faculty now. Raja Pandey followed by Dr. Basavaraj. Dr. Basavaraj, yeah. Can you unmute yourself and ask questions?
Good evening, sir.
Hello, Basavaraj. How are you doing?
Hi. I'm good, doing good, sir. Sir, one question is it better to introduce feeding tubes in patients with alcoholic hepatitis early if they're not taking adequate calories?
Yeah. So the question is, can we use feeding tubes early? I think most important is feed them early. I think that is important. How you feed them is different. Remember, you can put in a feeding tube, but these are patients, heavy alcohol use and all, at least from what I see, they don't tolerate nasal gastric feeding tubes really well. They don't like it. So it's very difficult to maintain it for a long time. I don't know, what is your experience today? Do you think they tolerate it well, Sanjeev or Yogesh?
So
No.
Do
we
they
have seen.
tolerate these people?
So we have seen that most of these patients who are admitted in ICU are very sick, very coagulopathic with high INR. So
Yeah.
they number one, the tolerance is an issue. Secondly, inadvertent, if some untrained nurse is putting a tube, you can really have a bad epistaxis which can jeopardize your whole treatment. So I think that it's a problem. But if you can do it very safely in a very sick patient, you have some time for 7-10 days, you can stabilize him. But overall, I would not give a blanket feeding tube because there can be complications with that.
Yeah, I
And
think
Yogesh is saying,
we rarely use Ryle's tube in these patients. They are able to take concentrated liquid with high calories, but in case they are puking and not able to, then Ryle's tube would be justified.
yes, so Baswaraj, I think it's just difficult to do it in these patients. That's all.
They won't
Okay.
accept it. If they
Dr.
Yeah.
Raja Pandey,
Good evening, sir.
yeah.
Sir, actually, I wanted to know in South India, we use low dose steroids along with low volume flex in most of these patients with severe alcoholic hepatitis and severe ALCAP induced ACLF. But the same practice is not used much in the Western part, where most of the studies from India have advocated the use of low volume flex and low dose of steroids. So, what is your take on that, sir? Do you think that flex can be a standard of care? In the case that we discussed prior as well, so if he did not have any chest infection, we would have done since he also had an AKI, and the creatinine is also around 3. So we could have done in India, we would have done flex for him, followed with a low dose of steroids, or probably done a CRRT. So what do you think? What is your take on that?
Yeah, so the issue of low dose steroids and plaques, I have not seen any study demonstrating that and against standard of care. So this Apache study that was done in ACLF, the international study that was done, the benefits were really marginal. It wasn't great. If you do statistics, yes, maybe it's a little better, but those are preliminary results. So at least for us, it is not standard of care, and Plex increases the cost quite a bit. You have to, again, I think for me, in general, and I'll talk a little about that in my next talk, simplifying to me is always better. Try the simplest possible way to treat, not the most complicated way of treating. Because the more complicated you make it, the less applicable it is. Plex means it has to be in very selected centers it can be done. But this is a disease that is in every primary health center across the country will have something like this. So even steroids become difficult at that level, just giving a tablet at that level without the monitoring. So I'm all for simpler treatments. And again, government can help here.
There is a question from the chat box, Patrick. Patient comes with the very violent and withdrawal symptoms. So while treating them with the sedatives, I think they slip into coma. So how to manage such situation? The question from the chat box.
So the question is sedation of patients with alcohol, and we use very short-acting drugs. So typically, these are done in the intensive care unit because the question is coma and aspiration in them. And the drug is what is it? It's metamethine. I'll get the name.
Dexmedetomidine.
Midazolam.
Dexmedetomidine.
Not
Midazolam.
midazolam. It's a very short.
Dexmedetomidine.
Dex.
That is the one.
Dexmed.
Correct.
Dexmed is the
Dexmedetomidine is what we've started using.
Yeah, that is the best one, I think. Okay, now choice is to Patrick. We can go into the second talk, or you want to have one more round of discussion with starting from Chawla.
So maybe we'll go to the second talk because I'm looking at the clock, and
Okay.
in about 45 minutes we should be done,
Yeah.
right?
Yeah.
So I'll go into the second. Shall I start sharing?
Okay, Dr. Chawla and Dr. Sanjeev, you agree with me? We'll go into the go for the
Yes.
second talk.
Yeah.
Option 2 will be better.
Yeah.
Okay, right. We'll move
Patrick,
on to
before you start, just two thoughts. One is the role of budesonide in patients with alcoholic hepatitis. We'll look for an answer after your talk. And second is, recently I came across a patient with alcohol precipitating autoimmune hepatitis. That was very interesting. I had never seen, but very recently I came across. I think go ahead with your talk.
I
and
think
maybe
I invite Dr. Sanjeev to introduce the topic. Again, invite the Patrick so
Yes.
that he will take a 30 minutes break now.
Right.
He's
Yeah.
enjoying
Thank you.
coffee now.
Thank
Okay,
you. Thank you
Sanjeev.
very much. Thank you very much, sir. It is my absolute honor and privilege to invite Dr. Patrick Kamath, who is our teacher actually in a way, because we have been following him for the last almost 3 decades. I can say that every hepatologist uses the MELD score almost every day in their practice. Yet many of the younger generation may not know the remarkable journey behind its development. MELD score has uniquely changed the way we prognosticate liver disease, and it is universally accepted all across the globe for liver transplant allocation. There have been some changes, modifications. UK may use UKL, but ultimately it's been used all across the globe. Today, we have a very unique privilege of hearing this story from the person behind this landmark achievement, and I'm certain that Professor Kamath's lecture will not only take us through the fascinating history and evolution of MELD score, but interestingly, it will provide us valuable insights into how a scientific thinking can be clubbed with clinical knowledge, and we can come up with something very unique which will change the way we deal with liver disease in decades to come. So we really keenly look forward to your lecture, sir. Over to you, Professor Kamath.
Oh, thank you again, Sanjeev, for that kind introduction. And actually, your second last sentence is the most important to me, actually. What I'm trying to show is how clinicians can really make a difference. So even though the topic is on how did I arrive at the MELD score, the journey and the impact, I want to make it a little wider. It's not so much about me. It is what I'm trying to show you is how all of you as busy clinicians can actually do some research which will have a big impact. Okay, so within this talk, I'll talk about how I also arrived at the MELD score and what we are doing now. So I'm not a clinician scientist. My main work is I see patients and I teach fellows, but in between I try and find some time to do research, okay? And what I'm hoping to do is inspire some of you to do research. And if among all those who have signed in today, if just one person, even if one person is inspired to do some research, then I think my talk would have been successful. So in this talk, I'll go over a job versus a career, why research is important to make your job a career, how it prevents burnout, some myths regarding research, process for carrying out research, and here's where I'll talk about the MELD score. There are some impediments to research, and finally some take-home messages, okay? So all of you ask yourself this question, do you have a job or a career? I hope all of you have a career. And what's the difference? Job is short-term, career's long-term. So in a career, you want to grow, you want to gain knowledge, you want to gain experience. So in a job, 30 years from now, you'll be doing the same thing that you're doing now. But in a career, you're going to be doing completely different things in the same field, but much better. Job is essentially collect some money, pay your bills, but career is about collecting experience. People in a job usually go home angry. Career, they go home happy. In a job, they really don't want to come to work, but those in a career really come energized. Okay, so I hope all of you have a career. Now, why is research important and how does research make your job a career? So let's talk about burnout. So it's a syndrome which results from chronic workplace stress. Characteristics are feeling of energy depletion or exhaustion, not putting heart into your job, and declining sense of personal accomplishment. I hope this does not apply to any of you, but it might. But certainly all of you work with people who demonstrate these features. So this is in the US, 63% of people had at least one burnout symptom. That was an increase. And only 30% were satisfied with work-life balance. Remember, your work may be going okay, but what about your family? Are you balancing that out? If you cannot balancing out, that again means you're likely to burn out sometime. So why is burnout important? At a personal level, and again, you'll probably have colleagues like this. At a personal level, these are people who have broken relationships. They start using alcohol, depression, and suicide. At the professional level, they're not very good doctors because the quality of care they provide is less. Patients are less satisfied. They don't produce as much as they should be. And because they're difficult to work with, people leave. So there's physician turnover. So what can you do about it? And this is work from Tate Shanafelt. He was one of our fellows before. Now he's at Stanford. He's a very good hematologist. He looked at physicians across the country and asked them whether they're doing something which they find really meaningful to them. And those who are spending more than 20% of their time doing something meaningful, much less likely to burn out. Now, meaningful to you may be different. It may be an endoscopic procedure that you really like. For some of you, it is teaching residents and fellows and medical students. And some of you, it might be research. Do something that you find meaningful. You're going to be much happier with what you work. And 20% means, say, 1 day a week spend on time, or 2 hours a day, you're much more likely to be at work. So take home message, spend at least 2 hours a day doing something meaningful to you that you really like doing as a doctor. And I'm trying to make the case that research will give you more meaning in your life and it will delay burnout. You'll have much more joy at your work. And I personally believe everyone should do some form of research at least. So if you look at people burning out in medicine, if you're seeing patients, let's say you're a gastroenterologist doing only upper endoscopy, colonoscopy, and prescribing PPIs and isopropyl, you're doing exactly the same thing. After 10 years, you're not going to feel happy. You're not going to feel rewarded or recognized. If you're seeing patients and teaching, you'll feel happy a little longer than that. But the people whose careers are the longest and the happiest are those who are seeing patients, teaching, and carrying out research. Okay? So, why should all clinicians do research? It gives you research ideas. We'll talk about that. You are trying to solve problems that you face day to day. People in the lab don't know what problems you have. You are seeing the patients, you have to find solutions to these problems. And when you solve these problems, the impact on patients is immediate. The moment your paper is online, you've already changed the way practice, how patients are treated. Basic research takes a very long time. So to summarize, research will make you an expert in the field. Once you have publications, people will recognize you're an expert. You'll have a career now, and you will reduce burnout. Now, there are some myths regarding research. All of you may be saying, oh, what's she talking about? I cannot do research. I don't have money. So the myth is that the only good research is funded research. So you'd think if I don't get ICMR money or DST money, I cannot do research. Not true. This is one of my favorite scientists, okay? You may or may not recognize her. This is Jane Goodall. High school education. She was 20 when she went to Africa. Just looked at chimpanzees, took a notebook, and started describing what she was seeing. So no formal training, became the world's premier primatologist. No education, no training, just observing and writing in her book. In fact, she was so good that she was allowed to do a PhD at Cambridge without even a bachelor's degree. So high school to a PhD. And I think the most important part of what she has done, it has told us about ourselves as humans. We've always thought humans are superior to other animals. But her work on chimpanzee really shows exactly where we are as humans. So she's done remarkable work, no funding or very little funding, all on her own, not much training. Myth 2. If you have a simple observation, it cannot have a major impact. Again, not true. You know, Barry Marshall gave a talk. That was a simple observation, huge impact. For me, I think even greater impact is what you all deal with every day. It started from the work of someone called Captain Phillips. He was a physician in the United States Navy. It was in Cairo in 1949, and there was a cholera epidemic at that time. And he found mothers breastfeeding their babies. Those babies were more likely to survive cholera than those who were not fed. He went to the Philippines. He noted during cholera, babies given rice water more likely to survive than those not given rice water. Just simple observations. So he started making rice water solutions, adding salt. There was too much sodium in that, but that was the basis of his research. And you might recognize more names there. Hemendranath Chatterjee, I think, had a really important paper, 1952 in Lancet. That to me was the first paper on oral rehydration solution. Unfortunately, his study was a bit complicated. He gave oral fluids, he gave enemas, he gave Largactil to prevent vomiting. He also gave some desi medicine. So that's why the world did not believe his study, but it was a Lancet paper. Robert Crane, sodium glucose co-transporter, which is the basis of multiple drugs, found out the right ratio between sodium and glucose. David Nallin and Richard Cash worked on getting the oral rehydration solution, and that time it was East Pakistan. But later in the Bangladesh war, the real hero was Dilip Mahalanobis. If you know, he died 2 years ago and posthumously was given the Padma Vibhushan. Remarkable, extremely humble man. And because of the work of all these people, there are 3 million lives saved every year just because of oral rehydration solution. And I think one of the greatest joys in my career was when I went to Kolkata. Mahesh Goenka arranged for me to meet Dilip. It was a great honor for me. And those of you who are interested in knowing the story of oral rehydration solution, it has saved more lives than almost anything else. Please read this. It's a fantastic article. So, busy clinicians have done research. Captain Phillips, the observation that has resulted in saving more lives than even penicillin. Coming more into hepatology, this is my friend and colleague Peregrines. His simple observations and work, how they've changed the management in liver disease, and then I'll talk a little about the MELD score. So this is Pera's work. As a fellow, simple things. He would ask his boss, is paracentesis safe? Boss said, study it and see if it's safe. Lancet paper when he was a fellow. Should we use diuretics or paracentesis? Boss said, try. Give some diuretics, try paracentesis. He said paracentesis was better. Use albumin, even safer. Levine shunt, not better. NEGM paper. All simple interventions. Tips for refractory ascites, effective, but no survival benefit. SPP, this is a really remarkable story. So, you know, at the end of your outpatient, the medical representatives come and they put samples on your table. So he had this patient who was getting infected. Later on, they realized this was SPP. He was getting infected. They didn't know how to treat. This was 1987, I think. Norfloxacin had come to Spain. Medical representative left a big bunch of packets with norfloxacin on the table. So the patient asked, what is this? So he said, you know, this is a new drug, which is not absorbed, and they think it prevents infection. So patient said, can I take this and try? They said, sure, why don't you take it and try? He took norfloxacin and didn't get SPP again. So then they did the studies and showed norfloxacin works. Again, simple observation changed the way how we practice medicine, cefotaxime, albumin, and there are many more. So all simple studies. When I look at every one of these studies, I say to myself, in India, there are probably 100 centers could have done this much quicker than they did it because we have many more patients in India. So think about this. You can solve problems very easily. You have a huge patient population. So let's come to the MELD story, okay? I went to Mayo in 1991. I left India in 1991. Towards the end of 91, we were planning tips, and we started first tips in January 1992. So I was using the CTP score. Some patients died. I didn't know why, but I thought maybe CTP was advanced. But then I remember this patient. I know her initials. Just one patient inspired me to get the MELD score. Only one patient. So she was 61 years old. She was diagnosed with liver disease at the age of 53. She had lost her husband the previous year. So there is this 22-year-old son with her. He has lost his father the previous year. Mother has refractory ascites. And I'm saying I'm going to do a tips on her. So he asked me a question. What are the chances of my mother dying post-procedure? So CTP score was 9. I said, oh, she'll do fine. Don't worry. We did a tips and she died 3 months later. So I realized I gave wrong advice and actually did disservice to the patient because if I hadn't done a tip, she may have actually been alive at that time. So that's when I said CTP is not good enough. I really need to figure out better how to predict who is going to survive TIPS, or at least do well with TIPS or not. So the question I asked is, how can we predict mortality risk post TIPS? And again, when you're doing research, don't do research for the sake of doing research. Do research on questions where clinicians want to know an answer. They want to know, is this a better way of doing it? Can I find a way of doing that? And once you do research, try not to do it on your own. You start off on your own, but once you get a good idea, once people see there's a good idea, you will have collaborators. And Ray Kim was my fellow. He's probably the foremost worldwide now in outcomes research, and he's the one who has taken MELD forward to MELD sodium and MELD 3.0. He's a superb researcher. So we are good friends. My former fellow, he's a colleague now and a friend. So I've had collaborators there. So think about that. Do something, get collaborators. Also very important, never give up, okay? This is another part of the MELD story. So Sid Phillips was my boss at Mayo. He was my mentor. So I wrote the paper and I said, where do you think I should send it? He said, straight away, New England Journal. He says, it's a new procedure. No one knows how to decide in whom to use it. You're showing how to use it. I sent it to NEJM, came back in 2 days, reject without review. They said, yes, we think it's an important question, but your calculation is too complicated for our readers, so reject. I said, okay. Rewrote the paper for gastroenterology. Came back in 2 days. I never quite understood what they said. They said, we are really impressed by all your calculations and your math. They call it math in the US. But the editor said, I don't understand why you actually did the study, because survival is not important in TIPS, because you should do TIPS only pre-transplant. Whatever the person was thinking, I don't know. But that was rejected. Rule here is never get angry and shout. You can abuse them 15 minutes only. More important, fix your paper. We said, okay, let me try and fix the paper. I sent it to hepatology. Rejected, was reviewed and rejected. So comment from the editors, you really think? It was a very sarcastic comment. They said, you think you can predict long-term survival? So when we wrote the initial paper, we were talking about 2-year survival we could predict. They said, really? And they said, just by the way, in case you don't know, hepatocellular cancer kills patients with liver disease, not creatinine. I said, okay. Took it back. Again, I rewrote the paper. I made it 3 months. The 2 reasons to make it 3 months survival. One is no one could say HCC developed in 3 months and kill them. So HCC came out, and at that time, 3 months was the median waiting time for liver transplant in the US. So I rewrote it extensively, had new figures. I wrote a letter to the editor and said, it's not the same paper. I'm reviewing it as 3 months. 3 months, they accepted it. A lot of revisions, we went back and forth, and then they finally accepted. So don't give up. If I'd given up at this stage, then MELD would never have come out. So it has now become the metric for severity of liver disease, organ allocation, as Sanjeev told you. It's used to stratify risk in alcohol-related hepatitis, selection of patients for surgery, TIPS, acute liver failure mortality risk, varicose bleed mortality. So it's used for many things. But again, we developed this in the 20th century. 1992, we started collecting data. I did it, handwritten records. I learned how to write records from my teacher in PJ, P.N. Rao. He would write everything in a register. So I wrote everything in a register about all these patients, including the labs. I do these calculations in between. But now this is a different century. That is old. The type of patient we develop the MELD score on is different. We are getting much more cardiometabolic problems now. So the question now, should we use digital tools? Again, basic rule in life, get a really smart fellow to work with you, okay? I've got very good fellows who work with me. And so one of them is Joseph Hahn. I'll show you his picture in a bit, who works on diffusion models. And we are trying to make digital twins. Now I'll try and make this as simple as possible, okay? So this is a picture of a dog. So we digitize the dog, and then you destruct the data by you keep adding noise. So you know exactly what sort of noise you had, and you end up with only noise, okay? Then this program will take the noise and it's called denoise it. Remove whatever you added, and it comes up with another dog. It's not the same dog, but it is extremely close to that dog. So that's called a digital twin. So Joseph took all the UNOS data, and we now have a synthetic US cohort. So we have 38,000 almost identical to this, but not the same. And I'll tell you why it's important in a bit. So once we did that, you can see the characteristics are almost identical, not the same, but almost identical. Original UNOS cohort, the synthetic UNOS cohort, okay? So now we have a group of patients exactly like the UNOS cohort, de-identified. But we also know a lot more about this. Did they have dialysis or not? Remember MELD and all, we don't have this data. We just have the number of the MELD. But here we have a lot of things, etiology, blood type, cardiovascular, we have many more things in these patients. When we looked at the survival of the UNOS data and our digital cohort, almost exactly the same, okay? So these are what we call digital twins. Still preserves MELD performance. So now why is this important? Let's say we take a patient with MELD 35. There is Yogesh, Sanjeev, Vivek, TSC, me. Let's take all of us at 35. But we know our muscle mass is different. Our cardiac disease may be a little different. We may have genes which repair better than others. Now, MELD has not picked up that. But with this digital program, we can find what is called a nearest known neighbor. We can find someone with 35, my age, male, lives in the US, type of liver disease, and everything, which gives you much more information than MELD. And so in that patient, we can say this individual, because I know this is how long the neighbor survived, this individual will survive this long. So we can predict much more accurately. The reason for this is important. Right now, if you're 35, you'll get a liver before 34. But once we use this, we know an older person with 34 probably will die before a younger person with 35. So our synthetic data will help us decide that. And we think we'll do a much better job with streamlining. And this is what Joseph Hahn is doing. Okay. But let's take it even further. This is the 21st century. Let's go early. Can we use simple AI tools to even diagnose cirrhosis? And why is early diagnosis at an asymptomatic phase important? So there are different risk factors for liver disease, alcohol, obesity, metabolic dysfunction, whatever you want to call it, viruses. It takes almost 30 years to get cirrhosis, and that's the compensated phase. Then they're asymptomatic, and then ultimately get decompensation. And then generally we are seeing these patients for not more than 2 years because they're either going to die or get liver transplant. But if we pick them up very early at the stage of compensated disease, we have 10 to 12 years when they're asymptomatic, where we could do a lot of things, where we could change the natural history of these patients. Right now, only 2 to 5% of patients are picked up at the compensated cirrhosis stage. We hope to increase that to 85% using simple tools. So what is a simple tool? It's a 12-lead EKG. Another one of my superstar fellows, Doug Simoneto, now my colleague. He's our program director for the fellowship program too. So the question is, there are ECG abnormalities in cirrhosis. Can we use an AI program in the ECG model to detect cirrhosis? So just a 12-lead ECG, 10 seconds. And what did we find? Yes, we can clearly do it. Extremely accurately, the ECG will tell you whether the patient has cirrhosis. We have a score, where the score will keep increasing the worse the liver disease. You can see that's the MELD score there. And here is the great thing. It keeps increasing, but when you transplant them, the score comes back to normal. So the ECG is telling you whether the liver is abnormal or normal. So you can see area under the curve 0.9, extremely accurate in telling you whether there's cirrhosis or not. So the next question was, if it can say cirrhosis, yes, no, can we predict decompensation? Like I told you, the score goes up as the liver disease gets worse. What did we find? Again, very good at predicting decompensation. Now, I won't go into the particular scores. 0.25 is the cutoff for 0.17 is the cutoff for cirrhosis. But let's look here. If we have a patient with a score of 0.25 on the ECG, we can say you're going to be alive in 5 years. No problem. The patient has a score now of 0.75 on our ECG score. We can say, unfortunately, 50% chance you'll die at 1 year, and it's extremely unlikely you will be alive in 5 years. So just an ECG is telling us all this. We took it even further. Now let's go to the community. That's where the diagnosis of cirrhosis.
Alert, missing adult, all clear in Charlton Building, desk R, subway level. Attention, security alert, missing adult, all clear in Charlton Building, desk R, subway level.
Yeah, sorry. Now we're going even further. Can we help the primary care clinician, because they are seeing the patients with cirrhosis? Can we help them diagnose cirrhosis very early? Okay, because they are not trained like us. So we did what we call a cluster randomization. We randomized clinicians. So picture in Thambaram, all the doctors will know the ECG, whereas in Chetpet, they may not know, Gumdipondi, they may not know. So that's how we randomized. In 45 clinics, we randomized primary care physicians. What did we find? We won't go over details. If they had the ECG information, they would then do an MRE or fibro test or biopsy, or whatever. The physician could do whatever they wanted to make a diagnosis of cirrhosis after that. So in the intervention arm, we diagnosed 3 times higher cirrhosis than in the standard of care arm. That means people who didn't have the ECG. But I think this is more important. When people didn't have the ECG, they only diagnosed cirrhosis when there was decompensation, or not only, 1/3 of them were decompensated. But in the intervention arm, we could diagnose cirrhosis very early. So at least, where are we going now? We're trying to use ECG. All this is various ways to try and predict outcome of patients. Now we're using ECG to predict screening and everything for cirrhosis. And why is this important? Because patients don't need to come to us. In a far-off place, we can still diagnose them with cirrhosis just based on the ECG. So now finally, I said, why you should do research? Let's go back to you. I see a lot of research being done in India, but ask yourself the question, is this high-impact research that has changed the way I practice? That's what we want to aim for. Treat patients differently, have better outcome. Low impact is no one is interested in that. High resource means a lot of people are required, a lot of funding. Low resources, you're doing it mainly on your own, okay? So case reports, good for your CV, but low impact. You can do it very quickly. I see a lot of validation studies done in India. This is what we call incremental research. unless you've shown a big difference from the previous study, no one really cares about that. So you've spent a lot of time getting research which no one's really interested in. Clinical trials are important. They change practice, but they require a lot of resources. Here is what you should focus on. Astute observations. If you pick up something, study that. That is the most important question. And also, remember, right upper quadrant, that is where the liver is. And what are the ideas? Fellows ask me, give me ideas. I say, I cannot give you ideas. Patients will give you ideas. So they'll ask you, why did I get this disease? If it interests you, study why people get a certain disease. They say, oh, this test, I don't want this test. Don't you have a simpler way to diagnose this? Try and find a simpler way to diagnose this. Or there are different treatments which you think is best for me. You can say, I don't know, try this or that. Or you can actually do a study and find out which is the best of many alternative treatments. Yes, what's your prognosis? Will I die? That's my main interest, is prognostication in liver disease. Or will my family get this disease? Again, good way, study families and find out. When you do research, find the time to write. Unless you publish, no one will know about your research, okay? I see many abstracts but no papers. No one follows abstracts presented at meetings. Write a full manuscript. Find time to write. You know, in between procedures, between patients, try and find time to write. You know, if you're waiting and your children are doing something, right. I wrote my MELD paper while my children were going for swimming practices. We tend to write a lot and then we cannot write anymore. Then we find it difficult to go back to the paper. And that's why the paper sits on your desk for a long time. Stephen King, the great author, said, always leave the last few sentences unfinished. So you know what to write, but don't write it. Go to sleep, and the next day you already know what to write. So once you start writing, then it flows. So you're avoiding a cold start. So always leave some part unfinished, and you know what to add on later. And then many of you are going to travel a lot. You're going to wait in the airport, flights, use that to write papers. Remember, Joseph is a great, nominated many times for the Nobel Prize in Literature. He said, every writer I know has trouble writing. So if you have difficulty in writing, don't worry. The more you write, the better it is for you. And there are going to be some impediments to your research. Most important is you yourself, giving up too easily. So don't give up. Nowadays, it's much easier to find a mentor or an environment. Find a mentor. But most important of all, find a good question. If you have a good question, you'll find mentors easily. So my take-home message is, try and become an expert, and research is going to make you an expert, okay? Make sure you have a career. If you see something, study it, ask questions. Find collaborators, find mentors, and this way you're going to find meaning in your work. Most important of all for research, find the time and make sure research is a priority for you. And believe me, you will be happier and you'll be less likely to burn out. Thank you.
Patrick, fantastic. Sanjeev would agree with me that it's one of the best the lecture I have ever listened to that. And the first 5 slides, what's the difference between job and career? In fact, I had a great opportunity to listen to one of his orations. Part of the slides I was aware of that. I was hoping to listen to him next time. It happened, and how he immersed the MELD score. That's the reason why the patient is the best person to kindle your research. I think I have 7 minutes. Do you pardon me that starting with the chit chat to know more about Patrick and Sanjeev and Chawla? Okay.
Yeah,
Patrick,
absolutely.
you are a hero to many, including me. Who has been your hero?
And so that's it. I actually have a lot of heroes, but if we come into medicine or in science, my heroes are always the people who, with very little resources, did a lot. So Dilip, all I wish was a great honor for me to meet him. Because I always said I knew about him. And if you know the story, there was a refugee camp, Bangladesh refugee camp. They were totally, no one knows exactly, but up to 10 million refugees were in the refugee camps, and cholera broke out and they were dying. So this refugee camp, I forget the name, was about 50 miles from Kolkata. So Dilip and his team were making up oral rehydration solution. So they knew the formula now. The Diarrheal Disease Research Center in Dhaka had come up with a formula, but because he's a Johns Hopkins researcher, so had come up. But he actually made up the thing. He told me he used to work 18 hours a day just making oral rehydration packets with a few others. Then they would rush and give it in the oral rehydration to the camp, and that decreased the mortality with cholera. And once people realized that, oral rehydration solution became, so to me that is great.
So Dilip
Jane
is your
Goodall,
hero. He is the hero. Chawla, who is your hero?
A hero, it's very difficult to decide. A lot of people are my heroes, but if you want me to name one, I think B.N. Tandon has been one
Okay.
person.
Your mentor, your teacher. Okay.
Yes.
Now
Yes.
hereafter I want one word answer because I have 20 questions. Sanjeev, who is your hero?
That's a very interesting
Now one
question.
word answer.
Yeah, I mean, one word answer is, I mean, if you ask me an inspiration, two persons I would name. One is Dr. John O'Grady when I was in King's, when I was with him, and I was absolutely, impressed by the
Okay.
ALF thing. And then when I look at the academics, then the person sitting in front of me, Professor Patrick Kamath, believe me, we have always followed him like a, invisible teacher all the time on our
Okay. Two heroes you told.
Yeah.
Patrick, what was your turning point in your professional career?
so I really think it's All India Institute in Nandi. There are 2 points. I think I was a reasonably good student in St. John's, but All India Institute Nandi got me interested really in thinking how to speak, how to present, and then PGI. If I owe one institution where I am today, it's PGI.
PGA, no? What was the most unforgettable professionally you learned from PGA? I mean, this is the one really made me different from what I am now and what you were.
The focus on education, how not only education, but how to communicate what you have learned. You're asked 1,000 questions in every rotation. So you learn how to speak and how to defend your thing. To me, that was really important.
When I joined Patrick, the thing that really inspired me, I mean, they're different from this evening rounds where the senior residents take a detailed rounds of the patient. So that was a great learning. I never seen any other institute where the evening rounds start from 5 and goes on up to 8 o'clock. So I think you are right, the PGA made the difference. Dr. Chawla, what was your turning point?
My turning point was entry into All India Institute. I had come from a very small place, and the academics there and the emergency management totally changed my view on that. But having been in All India Institute, I always felt that that institute is the greatest. But when I shifted to PGI, I thought there is even something more in PGI than what I learned in All India Institute. So I would give all credit to both these institutes, and they have transformed me totally.
So you have a case control study of All India Institute and PGA.
Yeah.
So you vote more in favor of PGA. And what is Sanjeev? What is your turning point in your life?
I think clearly my turning point was entering in hepatology when I joined my MD medicine and meeting Professor Chawla sitting in front of me here today. Believe me, we had a choice of selecting our thesis guide. And the moment I met Sir, I said like I have to be with Sir. And that was the turning point. I entered hepatology with Dr. Chawla and Dr. Dilawri was there. And so much.
Choosing hepatology was the turning point.
Yeah. And meeting Dr.
Patrick,
Chawla.
okay, thank you. Patrick, you want to change one decision in your life. would have made it little more better? What decision? I know you always make right decision, but it's a difficult question. Not beating me, don't tell me that.
No, I don't. But TSC, I think if you make a wrong decision, the thing is to find a way to change it. I think along the way, we make some decisions. I don't know if I've made really bad decision. If I say bad decisions, maybe I should have left it while it was going outside the off stump. I tried to slash it and I got caught. Those are the bad decisions. But career-wise, we always have this turns here and there, stop, falling down, getting up. I think that's part of it.
Okay. The next is, what is your unfulfilled ambition or dream? Yet to work on it. I mean, yet to you achieve it.
So, I'm interested in high altitude climbing, in trekking. So the most beautiful climb apparently is in Gilgit-Baltistan, where there's K2, you're surrounded by mountains. For various reasons, which are political, I will not be able to go there or get a visa to go there.
So you
But
want to
that is
visit some area where you are like to, what is the professional ambition?
So my profession is very clear. I want a next generation of fellows who are going to be much smarter than me. They already are and will achieve much more than I have. If they've not done that, then I'm a failure. If they've done that, then I'm a success.
Okay, one wisdom of advice to the younger generation. One important wisdom you want to say, what is it?
So it's little more than one. We neglect this. Always be honest. Always be humble. Always be kind to others, and always be helpful. I like to quote Carl Jung. If you know, he's the father of modern psychoanalysis. He has this line which particularly applies to us in our field. He says, master the technique. So be very good at endoscopy. Know the science. Know everything about it. But when you deal with a human being, just be another human being. That is my advice to the young doctors.
Okay. Which is the one proverb really like to quote and keep repeating that really change your life? What is the proverb?
Vidyati dhadatam vinayam. With knowledge comes humility.
Okay. What is the proverb you like to say, Dr. Chawla? That really makes me feel very good, and I would.
I think there's no proverb as such, but for the next generation, I can only say that whenever you deal with patients, come to their level, feel that you also could have been a part of that patient's relative. So be a part of the patient and you would be able to please everyone.
I liked it. You nicely changed the question.
Because finding out a proverb would have been difficult.
Last one thing, Sanjeev. What is your the philosophy? I mean, proverb.
Well, I've been inspired by one saying right from my medical school days. It is, a great physician is one, a good physician is one who treats the disease very well, but a great physician is the one who treats the patient as a whole. So that is why I believe it's not the treating disease, treating the patient as a whole.
Thank you. Thank you very much. A lovely evening. Then we had a fantastic speaker. The first speech, I mean, the lecture was on the current problem of alcoholic hepatitis. Then we see that problem. There many people come and ask me, why do you want to ask to research? I just see the patient, earn my money and relax myself. I'm not made for research. I think you made a fitting answer in that. What is the difference? You had a forethought about burning out and how research can help you, and how research is not only going to be useful, any online submission, but how the future generation going to look at in a particular disease. That's a fantastic, inspirational talk that I've listened to them. Once again, you proved, Patrick, that you are a master speaker and orator. And the second speech was very difficult to prepare. I like the way you carried yourself with the job and what is the career and how to end up. And ably moderated by Dr. Chawla and Dr. Sanjeev, and a wonderful panelists, Mitra and Ashwin, two PG faculty. We had Raja and the Baswara. And what is very important is we could spend time, and despite his MELD score being quoted every now and then, most of the places. So wisdom with the humility is a standing example there. So we big round of applause to all the people there. And thank you very much for this wonderful thing. And we look forward to seeing you next month for ulcerative colitis and Crohn's disease talk. Usually going to be very, very interesting and current topic. I request all of you to join us. Thank you very much. And I send warm greetings to American College of Gastroenterology on your behalf. Thank you.
Thank you, sir.